Thanks, Aditya, for making me a part of this wonderful instruction course, and thanks to AIOS. Uh, Aditya, is my slide visible?
Yes, so your
Yeah,
slides are visible. Please go on.
sure. Uh, so choroidal thickness is increased in the patients of CSR when we see it on enhanced depth imaging, and it is primarily due to dilatation of the choroidal vessels, and it is greatest in the acute CSR, followed by chronic CSR, and followed by the normal eyes. Now, the same order is maintained when we look at the subfoveal choroidal thickness. And they were consistently higher in the same locus of the fovea, that was 750 microns from the fovea, suggesting that it is more of a localized disease rather than a diffused one. And the increased CT was also seen at the leakage sites in acute or resolved CSR. Now that indicates that we should repeat the scans at the same locus during the follow-up visits to pick up any recurrence. Here we can see that there is a diffuse choroidal thickening with thinning of the choriocapillary layers, and here we can see a focal increase in the choroidal thickness. Well, another important marker is the choroidal vascularity index. It's basically the ratio of the total choroidal vascular luminal area and the total choroidal area on OCT. Well, the choroid comprises of the choroidal vasculature and the interstitial stroma. Now, increase in CVI basically indicates there has been an increased vascular luminal area, and this increase is more in acute cases as compared to the fellow eyes and the age-matched eyes. Sometimes in the fellow eyes also it was higher than the age-matched eyes, indicates that there is bilateralitis of the CSR. And it does not change or improve with laser photocoagulation. That's an important point. Here we can see how CVI is calculated. Well, the top scan shows neurosensory detachment. There is elongation of the photoreceptor layers in patient, indicating chronicity. And middle scan shows there is an automated algorithm to mark the choroidal boundaries. And then the bottom scan shows the calculation of the CVI. Another important biomarker is the hyperreflective dots, which are correlated with the subfoveal choroidal thickness, central macular thickness, and the height of the neurosensory detachment. Well, the mean count of this HRDs is acute disease was significantly higher as compared to the chronic ones, and it may be due to the inflammatory response in the retina and the choroid. Here we can see how the HRD is calculated. Well, the original scan is at the topmost. The middle scan shows the choroidal boundaries, and finally, the choroidal hyperreflective dots quantification is done. Another interesting sign is a flat regular PED sign, which can be picked up on the regular SD-OCT. It's not unique to the CSR patients, and it denotes a split in the RP and the Bruch's membrane. The important point is that it is predictive of type 1 CNVM, which initially may be non-exudative, and the treatment modality hence changes if there is type 1 CNVM. It's important to rule out CNVM in these cases, and OCT, angio, FFA, and ICG are also more useful than just OCT in these patients. Now, subretinal fluid basically, has optical density ratios which are slightly higher in PCV patients, as CSR and PCV patients may have similar clinical angiographic and tomographic findings, and they provide an insight to the pathogenesis. That is, difference in the SRF protein content highlights the integrity of blood-retinal barrier in both the disease processes. Here we can see the flat irregular PDs which are noted. Now, in CME and cystoid changes, CME is basically cystoid changes along with leakage on fluoresceint angiography, whereas CMD is cystoid changes without leakages on fluoresceint angiography, and CMD indicates that there is a visual decline and it is a poor prognostic factor. The treatment can be challenging. It may require intravitreal injections or eplerenone. Here we can see a case report in which they had shown the effect of eplerenone uh, on patients with cystoid macular degeneration following a month of therapy. We can see a subsequent changes which comes in the OCT. Here is a patient with 1 month of history and neurosensory detachment, which can be seen in acute CSR. Here, elongation of the photoreceptors can be noted after 4 months of the disease activity, and in a chronic case, a loss of photoreceptors and the RPE layer can be noted in the bottom scan. Now, retinal pigment epithelium integrity was assessed by Gupta et al. And here we can see a PED and a flat irregular PED over here. On a transverse C scan, we can see a PED which is noted over here with the micro rip noted, which gets resolved following treatment. And pachychoroid pigment epitheliopathy is basically RP abnormalities and pigmentary changes affecting the areas of choroidal thickening without any signs of SRF. And basically, this is a part of the spectrum of pachychoroid, which also includes PCV. Mottling of RP, irregular RP elevations comes as drusenoid RP lesions with absence of dross, soft drusins. The clinical features do resemble that of CSR. Sometimes these patients are falsely labeled as patients with age-related macular degeneration. It falls in the spectrum of pachychoroid. Here we can see the RP monitoring and the changes which are denoting of PPE. Thanks.